It's, next up, we have a GEDI talk by Dr. Aparna Hegde, where she will share experiences as the founder of the NGO ARMMAN. Just a little bit of a updated bio on Dr. Aparna as she does come up here. Dr. Aparna Hegde is a Stanford and Cleveland Clinic trained, internationally renowned urogynecologist. She is the founder of the NGO ARMMAN, which creates scalable mHealth, mobile health-based programs to impact maternal and child health in 19 states of India. Their reach currently is 28 million women and women and children and 252,000 frontline health workers. Dr. Hegde is an associate professor and the head of the Department of Urogynecology at Kama Hospital in Mumbai, one of India's first university-based centers of excellence in the field with a fellowship program. Dr. Hegde is the founder, Dr. Hegde is an NIH grantee and chair of FIUGA, the foundation arm of IUGA, which is the International Urogynecology Association. She is, now this part shouldn't be surprising given everything I said earlier, but Dr. Hegde is a Skoll awardee in 2020, a senior Ashoka fellow, and was featured in Fortune magazine's 50 Greatest Leaders of 2021 at the 15th spot. And with that, please welcome Dr. Aparna Hegde.
Okay, how can I switch? Yeah. Thank you, Vishal, for the kind introduction. So, whenever I come to a Dasra meeting, I remember, when we were just 3 people in ARMMAN, I was still in the US, Stanford, and, to bulk up the team, I had Dasra, right? So, I remember the meeting I had with, they were on Zoom, right? And then I remember we used to have our, when I used to interview candidates, we would have it in Dasra's office, right? So we started from there. It's been a long journey, a wonderful association. And Dasra has been a part of everything we've done. So I can't even begin and, and tell you everything. Just know that all of this is shared successes. Thank you. Yeah. So, yeah, of course. Thank you, Dasra. Vishal being the first one, right, Vishal? Yeah. Yeah. So we'll talk about how we leverage technology to create scalable solutions in maternal child health, right? So the story of ARMMAN starts during my medical residency, right? One day, Rupa arrived, convulsing with hypertension in labor. When I opened her papers, I was stunned. I could see my own handwriting. I had seen Rupa in the 3rd month of pregnancy, but she never returned. And I was racked with guilt. Did the overcrowding in the clinic mean that I had no time to counsel her about the danger signs, why she needed to come back for antenatal care? I saw these stories daily. Pervasive systemic problems leading to loss of lives of mothers and children are completely preventable. A woman, in the next 1 hour, 3 women are going to die in childbirth somewhere in India. 2 children under age 5 die every minute in the country. And these are because of pervasive systemic problems, both urban and rural. I don't have time, but the kind of stories I've seen in Mumbai during my residency, really boggles my mind. It's Mumbai, right? And you can imagine rural India. And I realized early on that if I really want to impact lives, I had to go into the community and affect systemic issues. 2 big issues I saw was, one of lack of access to preventive care information, both in urban and rural India. Because of overcrowding, ASHAs are not trained, the health workers are not trained. So the thing was that we needed to inform them and handhold them through pregnancy and infancy. And on the other hand, we have to train health workers early enough, properly, so they're able to pick up the risk factors in time, refer in time, and manage in time before it's too late, right? And then the mobile phone came to India. The kind of thing, India's magnitude of the problem is so huge that when it spread through the country in 2 years, it became, incredibly obvious to me that it's a great tool to reach out to women and health workers alike directly in their homes. We can inform women through pregnancy and infancy, handhold them literally weekly, so they demand care. On the other hand, use a mobile phone to train health workers at every referral system. So they're able to give care, and so then, there's no delayed or complicated referrals. So our whole goal is that we reduce the number of delayed, complicated, irrational, misinformed referrals to tertiary hospitals like mine. So they're all overcrowded, and there's overall reduction in maternal child mortality and morbidity. And that's the journey we've been traversing on from 2008. I founded in ARMMAN 2008. It was very difficult to get the first penny into ARMMAN. It took me 5 years because it was one student talking about scalable solutions. Indian NGOs tend to be local, this health space tend to be local-based organization, and homegrown scaled solutions are very, those days, using technology, very difficult to convince people. But finally, we are here, Yeah. So what are the principles we use, right? We don't use just technology. You just can't take numbers and send calls, right? We have something called as tech plus touch. Traditional models, it's very difficult to scale across the country because it's too resource heavy. You can't have health workers that you create parallelly to the government. So what we do is we use technology because we can reach out to women health workers more often, weekly, as often as we want to and they need. But we also have touch points, right? So tech plus touch. Touch points for enrollment, touch points for feedback, answering questions. But because you're using technology to do the heavy work, you can keep the number of touch points required as absolute necessary so that it's scalable, it's cost effective, and spreads through the country, right? That's what we've done, tech plus touch. Also, we don't create our own parallel network. We leverage the existing health worker network of the Government of India. So all our programs are in partnership with the Government of India. We proved our concept, and now it's all with the Government of India because that's true scale, that's true sustainability. You can't be scaling up massive scale programs of your own through the country. And everything is evidence-based, right? I'm going to talk about equity and gender, which is now really important for us in the next 5 years, but that's what has been added on, right? Equity-based solutions and gender transformative approaches. Right? So the first program we started off with on the beneficiary side was M-Mitra. It's our own program. So M-Mitra is a free voice call service that sends timed and targeted preventive care information directly to the phones of the enrolled woman in their chosen time slot or language preference. Right? And we have literally twice a week in pregnancy and twice a week in infancy, hand-holding women with a so we have 3 tries for every message in their chosen time slot. If they miss all the 3 tries, there's a missed call system, and there's a call center also to answer any queries. We reached 2.7 million women in 9 states. So the Government of India came to us, and there's a similar program called Kilkari of the Government of India, which we took over in 2019. And now Kilkari is in overall 18 states, and we've reached 28 million women overall, right? And it's similar to M-Mitra. On the other hand, so women are informed, so they'll access care. On the other hand, we have health worker training program at every level of the cadre, right? So the first frontline health volunteer is the ASHA. And ASHA doesn't get much training when she becomes an ASHA volunteer. So we run the Mobile Academy in collaboration with the Government of India. It's an mHealth-based refresher training program, again in 17 states, and we've trained around 252,000 ASHA workers. And both Kilkari and Mobile Academy will scale through the country in the next 5 years. What we also want to do, and government has given us permission to do that, is that we are going to go on to version 2. And this is where equity really comes in, right? So both Kilkari and Mobile Academy version 2 are going to be fit for purpose approach. We call it blended tech plus touch. Because what we realize is more the need, more the hand-holding required. So what's going to happen in Kilkari is that all low-risk women, there's nothing in no risk, there's no woman who's no risk, but all low-risk women are going to get either IVR content or multimedia based on the technology access. But the minute they have any high-risk factor, mother or child, we're going to have more hand-holding, more targeted content, more multimedia, more two-way communication, call center, WhatsApp access for asking queries. And if they're equity encumbered, right? If you're a Dalit woman, if you're a Muslim woman, you are tribal, migrant. I mean, we work in Bastar and the kind of places, and there it's very difficult to even go across to them through the ASHAs. So what we're doing in these parts is we are doing a pilot with UNICEF where we are leveraging the self-help women's group, who are women drawn from the same villages, who speak the same language. So through them, we are enrolling women into Kilkari. So, and more targeted, again, information, hand-holding. So this is the blended model that we are going to be doing in the next 5 years. And we are piloting it currently, and with the Government of India's permission, scaling through the country. Same thing with Mobile Academy. Mobile Academy is now going to be multimedia, two-way communication, long-term hand-holding. And we're going to answer any queries the ASHAs have in the field through call center or WhatsApp. Again, during COVID times, because we had this whole database of ASHAs, we could really handhold them, right? So similarly, if we go on to this long-term handholding, any new pandemic strikes, etc., we can be, supporting the ASHAs. And along with that, there's going to be system strengthening, right? So we are working very hard improving database of the Government of India that informs our programs, improving review processes within the health system, sending data, analyze data back to the health system at every level so that these programs are integrated within the health system. Even though they're Government of India programs, they work in their own silos. So the system strengthening is also going to be a very important part of our next 5 years plan, right? And lastly, a very important program that we're doing in Telangana is integrated high-risk pregnancy management. So ASHA's mobile academy, then you have the nurses, medical office specialists, and that's where the death hub happens. Because each level of the cadre has absolutely no idea of their part of the role, what are they supposed to counsel, how they're supposed to refer, what to do when the woman is sent back, right? And I had brought this to the Government of India's attention when I was a part of the Antenatal Care Guidelines Committee of Government of India, and then they allowed us to do, create protocols. So we created policy now for every cadre of the health system, which actually treats high-risk conditions. We've created color-coded, algorithmic, large, detailed, standardized protocols for management. Now that's become policy in Telangana. It's a pilot state for us. So the protocols become policy. And now we are training 9,000 nurses, 1,500 medical officers, and 350 specialists, both through face-to-face training and a learning app. All the content is becoming a multimedia, two-way communication, interactive quizzes, simulation, because everybody has a tablet now, right? And when you go into the field, if you have any queries, we will have call center and WhatsApp support for you. So really surrounded by support. And we're also tracking. So we've trained the health workers, they're implementing, and then we're tracking all the pregnant women with high-risk factors because all of this content is getting layered on the database of the government. So a woman gets pregnant, has a high-risk factor, we track her end-to-end. This will lead to dashboards at every level. So we can know where refresher training is required. Going forward, what's going to happen is, Telangana is like a pilot state for us. Kilkari and Mobile Academy go to Telangana next. So imagine all the databases talk to each other in the back end. So if a part of Telangana is doing very badly in pregnancy-induced hypertension, Kilkari can inform the women more, Mobile Academy can train the ASHAs more, and obviously the integrated high-risk pregnancy management can train the rest of the cadre. So and we have AI integrated. We have a long-term collaboration with Google and Harvard to use AI. So we're already creating models to predict risk factors and improve program efficiency. And this is the pilot I was talking about, right? Equity. So our these are like, for the next 5 years, these three are going to be pillars of our programs. What we realize when mHealth programs are created, technology programs get created, they have an equality lens. You create a program, you expect everybody to get them. It doesn't happen like that. To get to the last mile of the last mile, you really have to have nuanced programming. I told you, there's a program called Swabhiman with UNICEF, where we're going through the self-help women's groups. Similarly, what we are going to do for equity is that we are actually going to hold ourselves to it. Our monitoring framework is getting expanded from efficacy and effectiveness to efficacy, effectiveness, equity, and empowerment. We're going to actually disaggregate all our impact metrics based on equity and gender. The thing that struck me is under 5, when we do our impact assessment, we don't look at what is happening to the girl child separate from the male child. That's going to be our focus going forward. Gender, again, very important. We think that it's a woman-led organization. We work with women, we're gender sensitive. It's not true. So we're really transforming ourselves from gender-sensitive approaches to gender transformative, where it's not about only accommodating to the woman's realities, but actually creating environments where she can stand up. Both the woman and the health worker can stand up to the patriarchal communities that they live in. Lastly, empowerment. What is the intangible link between information and behavioral change? So we're really holding ourselves to measure that because we don't really understand that. Right, so we've created an empowerment tool for women and for health workers, and we're going to assess it and based on the research, because we're very research heavy, go and iteratively improve our program. So this is our commitment for the next 5 years. Thank you. One last line is that in the next 7 years, Vision 2030 is to go to 70 million women and their children through the country, and 850,000 health workers. Yeah, thank you.